Okay, so today we're going to be talking about early mortality and suicide among persons with serious mental illness. So this is our first session of September, and September is Suicide Prevention Awareness Month. So you're going to be hearing about suicide in different kinds of ways from us throughout the month, even though you do tend to hear those throughout the year and over the years that we've been doing this program. But today I'm going to focus in a bit specifically on the populations of people with serious mental illness. So overall, and this is a stat that I feel like all of us know and something that we have, that isn't new, but we see this number very often, this 10 to 25 year reduced life expectancy. So individuals with serious mental illness do have a reduced life expectancy compared to the general population. And in most of the literature, the SMI designation typically is defined as having a diagnosis of schizophrenia and or bipolar disorder. Sometimes you will see major depression included in that definition, but kind of that psychosis spectrum of things. When you look at a lot of the literature that I did for today, other mental disorder tends to be defined as kind of depression, dysthymia, anxiety, obsessive compulsive disorders, PTSD, attention deficit hyperactivity, and eating disorders. And literature over the years has demonstrated that mental illnesses are generally associated with premature death kind of across the board. The shortest life expectancy tends to be among those patients that have a substance use disorder, but having a combined substance use disorder, severe mental illness does tend to reduce that life expectancy even more. And in a study on VA populations, substance use disorder, serious mental illness, and post-traumatic stress disorder diagnoses were all associated with a shorter life by more than a decade on average, while depression and anxiety diagnoses were associated with a life that was shortened about 6 years on average. And overall, these individuals have the kind of highest risk of mortality at an early age or earlier age. Why are there, shortened lifespans for this population? There's a lot of different factors. So modifiable health behaviors, including poor diet, sedentary lifestyle, substance use, which includes tobacco. Those cause about half of the early preventable deaths in the U.S. population. So these, along with the other standard social drivers of health, are linked to shortened lifespans for individuals with serious mental illness. Individuals with serious mental illness often experience inequities in a wide variety of social drivers of health, including stigma, poorer access to care, economic disadvantages that can contribute towards poor mental health and premature mortality. Comorbidity of physical and mental health conditions absolutely contributes. And along those lines, some of the literature that I pulled from today talks about multimorbidity, which impacts clinical complexity and often lowers the quality of care for these populations. Halstead note in their 2024 article that having multiple physical illnesses is more often the rule rather than the exception for people living with serious mental illness. And given the entangled, non-modifiable and modifiable risk behaviors and risk profiles of this cohort regarding both genetic, developmental, health risk behaviors, and systemic factors, these individuals tend to have more physical multimorbidity than those without, and also have an increased likelihood of developing these conditions at a younger age, which leads to poorer outcomes. These risks then can become further aggravated by the physical side effect profiles of many common psychiatric medications, particularly certain antipsychotics, and they have a wide array of cardiometabolic, neuromotor, and endocrine side effects. All of this can be further intensified if polypharmacy occurs, so where individual ends up prescribed multiple concurrent psychiatric medications. Exposure to physical multimorbidity at that younger age can amount to greater lifetime exposure to chronic physical health issues and physical health disease. And authors generally have hypothesized that increased longitudinal exposure to chronic disease contributes to poorer health outcomes faced by those with serious mental illness. So showing that premature mortality, increased rates of disability, and also a greater health economic impact. One of the studies I looked at, the Trivedi study, looked at veterans being treated in the VA and the proportion of individuals who died by heart disease, cancer, cerebrovascular disease, influenza, kidney disease, chronic respiratory disease, and sepsis were similar across groups, whether that was with or without mental illness. When they looked specifically at substance use disorder, the percentage of deaths by accidents, alcohol-related liver disease, assault, and HIV were highest among those with substance use disorder, and considerably higher when you compare them to those living without any type of mental illness diagnosis. Notably, about 6.5% of deaths among individuals with substance use disorder were due to that alcohol-related liver disease, compared to less than 1% of individuals without any mental illness. A greater proportion of PTSD, substance use, and severe mental illness deaths were deemed accidental compared to those individuals who had depression and anxiety. And they also referenced some earlier studies that show that depression was associated with worse mortality than those veterans without a diagnosis of depression. In addition to all of those reasons for there being premature mortality, suicide is a leading cause of death for people with serious mental illness, and people with serious mental illness are overrepresented in the suicide deaths. A retrospective analysis of suicide deaths in individuals over 18 years old from the National Violent Death Reporting System, looking at the years 2003 to 2017, there were 174,000 suicide deaths during that time. 8.7% had a known serious mental illness, 33% had other mental disorders, 58.2% had no mental illness that was known of. So while people with serious mental illness represent approximately 4% of the total U.S. population, they did account for 8.7% of the deaths from suicide. So this data, and they highlighted that particularly individuals with bipolar disorder are highly overrepresented in suicide deaths. During that time period, the study indicated that suicide was definitely a leading cause of death among people with schizophrenia, ages 15 to 44 years old in the U.S. Disproportionately more females with serious mental illness died from suicide relative to males with serious mental illness. Over 1/3 of males and 1/2 of females with serious mental illness had prior suicide attempts during that time. And relative to people with other mental disorders, serious mental illness decedents were younger. They were more likely to have previous suicide attempts, as I said, and more likely to have co-occurring drug use. But problems with intimate partners, poor physical health, recent institutional releases were most common precipitating factors for these individuals with serious mental illness who died by suicide. And firearms were the most common method for males, with self-poisoning accounting for the majority of females. And while it is important to remember that suicide is a leading cause of death for people with serious mental illness, and that people with serious mental illness are overrepresented in suicide deaths, the additional reality is that most people who die by suicide do not have a diagnosed mental illness at the time of their death. So that is something that is really important for all of us to remember. Among decedents, relationship problems, relationship loss, life stressors, recent impeding crises were common across all groups with or without a known mental illness. And firearms are the most common method of all for people to die by suicide. But those without a known mental illness were more likely to die by firearm than those with a known mental illness. Among those with toxicology results, decedents without a known mental illness were also more likely to test positive for alcohol, but less likely to test for any substance. So what do we do? I mean, this comes down to, we know lots of stats, but what do we do about any of it? So it's important for us to try to look at addressing multimorbidity, systems issues, risk and protective factors in order to not only improve the quality of life, but the length of life for people with serious mental illness. So as I said, I looked at a couple articles that looked at multimorbidity. So that's that presence of multiple chronic conditions. And conditions might interact in ways that can either have positive or negative consequences. These interactions generate the need for greater vigilance when evaluating patients for comorbid conditions. The research varies, but studies that look at comorbid mental and physical conditions point to fair potential for suboptimal care management, and especially as you add conditions to the list. They know one study that looked at hypertension management and found that it was less aggressive if a patient had an unrelated comorbidity such as arthritis, cancer, or depression. Other studies have shown that patients with mental health conditions or chronic pain are at risk for receiving suboptimal care for hypertension, diabetes, heart failure, arthritis, chronic obstructive pulmonary disease. Multimorbid patients tend to have frequent contact and intensive contact with the healthcare system, but at the same time, with each additional condition generates greater opportunities for that suboptimal management, including missing a diagnosis, inadequate treatment in some space, and then access and communication barriers across the various providers that would be needed to address each of the conditions. And additional challenges arise when patients have several clinicians involved in that care, so increasing the likelihood of conflicting advice, redundant diagnostic tests, and impractical treatment regimens. So our approach to complex patients should involve acknowledgement of the interactions between biological, economic, cultural, environmental, and behavioral forces, all of our social drivers of health, those social determinants of health. And it's important for us to incorporate these dimensions into our clinical assessments to try to ensure the care is aligned, with all of the patient's needs, goals, and preferences. The Zillman article provided a conceptual framework for depicting the influence of comorbidity number, characteristics, and interrelatedness on clinical complexity and quality of care for patients. And in the proposed framework, the relationship between multimorbidity and quality of care is influenced by the patient's number of chronic conditions, the comorbidity characteristics, so things like symptom intensity, clinical dominance, and comorbidity interrelatedness, all of which increase the complexity. So interactions can occur in the context of both concordant and discordant conditions, and the presence of one condition might influence the clinical management of the other. Adhering to even a guideline for one condition could exacerbate a second condition or increase the risk associated with that condition. So looking at the chart and all of the little kind of notations on it, I'll try to go through this real quickly. But a patient's sheer number of conditions can generate clinical complexity because of the cognitive burden required to try to look at all of these clinical issues at once. So at A, with an increased number of conditions, there's an increased likelihood of one or more becoming symptomatic or dominant due to clinical severity at any particular time. B, all of which increases clinical complexity. C, generates quality of care challenges. D, these conditions also increase the likelihood of conditions interacting with one another, which affects management decisions and potentially increases that comorbidity interrelatedness. At E, that comorbidity interrelatedness frequently occurs when two conditions are discordant or unrelated in their pathogenesis, but can also occur in the presence of conditions that are asymptomatic but concordant. So examples that were given are diabetes influences the medication of choice for hypertension. F, that comorbidity interrelatedness can cause clinical complexity through a number of mechanisms, as depicted in the box. G, outside of that clinical domain, there's a number of important contextual factors. Patients' behavior, their social support systems, their environment also can generate clinical complexity. H, those quality of care challenges, and I can moderate the relationship between comorbidity, interrelatedness, and quality of care. So all of these things are highly bidirectional and influence one another. And that's why integrated physical care and integrated physical and mental health care is absolutely critical. So primary and secondary prevention of physical multimorbidity should be clinical priority in all people with serious mental illness, given their increased risk of developing multiple physical illnesses and given the increased risk of developing them at a younger age. So, that primary and secondary prevention, lots of universal screening and screening for things earlier on. Beyond this, that need for monitoring and screening of the physical disease by primary care and physical health practitioners and psychiatrists and their psychiatric teams in tandem. So that integrated care is really how we potentially best address this. But aside from that, we really need to aside from figuring out how to coordinate, collaborate, manage care efficiently to truly improve the length and quality of lives of people with serious mental illness, as a society, we need to do better at starting to address the risk and protective factors. So addressing the risk factors, promoting protective factors. The SIPL study interviewed a group of peer supporters, and individuals with severe mental illness. And for that group, they included those with a documented diagnosis of schizophrenia, schizoaffective disorder, bipolar or persistent major depressive disorder, and that had a comorbid diagnosis of a cardiovascular disease, obesity, diabetes, or COPD in their medical chart. And they identified a variety of themes within risk protective factors, including things like social connectedness, treatment, coping, physical health and wellness, resilience, and mental health. And one of the major themes that came up over and over again was social connectedness. There are studies that point to stronger social relationships being associated with a 50% increased likelihood of living longer. So it might be interventions that address social connectedness that also address health behaviors and resilience factors that might be most successful in preventing early mortality. Access to services and continuity in relationship with service providers are also things that influence health. Leveraging the power of social connectedness using peer-led integrated interventions, and really, say last but not least, really focusing on hope, optimism, purpose, and a sense of self-worth. All of those are foundational, and they can play a really essential role in the physical and mental health of individuals. They can promote engagement in our own care and therefore improve health while also making life worth living and health worth maintaining. So all of those pieces are important to the larger integrated care perspective. So our key takeaways from today: individuals with serious mental illness have a reduced life expectancy. Suicide is a leading cause of death for those people, and people with serious mental illness are definitely overrepresented in suicide deaths. But most people who die from suicide do not have a diagnosed mental illness at the time of death. And to address this, we have to address multimorbidity, systems issues, risk, and protective factors in order to improve the length of life and quality of life for the individuals that we work with serious mental illness. Here's a list of references, and I'll stop my share.